Hello, everyone. Thanks for joining across all the many time zones that are represented here, and welcome to Persyst Grand Rounds. This is an online series of lectures hosted by Persyst, covering topics related to advanced EEG analysis for improving outcomes in both neurocritical care and epilepsy monitoring environments. I'm Marie Terrell, Director of Product Management with Persyst, here to introduce our speaker and topic for today's Persyst Grand Rounds. Next slide, please. So through our customers, we understand the importance of investing in the EEG community through education, where expertise and knowledge can grow towards the utilization and implementation of EEG and quantitative EEG. The goal of Persyst Grand Rounds is to provide a platform for those with clinical expertise on topics of advanced EEG analysis as a way to connect with a broader community to share their experience and knowledge so that we can all learn and grow together. Each online lecture features an experienced epileptologist or neurophysiologist presenting on a topic of their choice as it relates to EEG monitoring and analysis. And you can visit our website, persyst.com/grandrounds to keep up to date. Next slide. So the opinions and viewpoints of each speaker are solely their own and do not represent Persyst or any other commercial entity or commercial interest. Speakers are not required to include Persyst, its software, products, or services. The content presented was not prepared or edited by Persyst, and Persyst is not providing any form of compensation. All right, next slide. Before I get into the intro, I just wanted to give a little shout out here. We have 300 people registered for this webinar. And, as we go into 2025, this is, we're entering our 4th year of Persyst Grand Rounds, which is pretty awesome. So I wanted to just acknowledge all the past speakers and thank them, including Dr. Lallas, who is our speaker today. We really do consider this a contribution to the EEG community, and they are providing a really valuable service for us and the community. So thanks to everyone that has contributed over the years. And with that, I will mention that this talk is being recorded and will be made available to all the registrants afterwards. There will be a time for a Q&A after the talk, and so you can write your questions in the Q&A box. There's a button at the bottom of your screen that says Q&A. And now we will get into why we're here. Today, we welcome Dr. Matt Lallas. Dr. Matt Lallas is a pediatric neurologist with the Nicklaus Children's Hospital Brain Institute. He earned his medical degree from the Rosalind Franklin University of Medicine and Science in North Chicago, Illinois. Dr. Lallas completed 2 years of pediatric residency training at Children's Hospital Los Angeles in California, followed by a residency in pediatric neurology at the same institution. He then pursued a fellowship in clinical neurophysiology at Nicklaus Children's Hospital. His interests encompass clinical epilepsy, including the care of patients with medically resistant epilepsy with treatment through surgical, neuromodulatory, or dietary methods, analysis of EEG data for 3D representation and correlation to imaging, as well as complex epilepsy related to genetic conditions, including channelopathies and tuberous sclerosis. Dr. Lallas has 3 board certifications through the American Board of Psychiatry and Neurology and is certified in neurology with special qualification in child neurology, clinical neurophysiology, and epilepsy. He is a member of the American Academy of Neurology, American Clinical Neurophysiology Society, and the American Epilepsy Society. His work has been published in peer-reviewed journals, and he has presented at numerous medical conferences. Dr. Lallas is employed by Nicklaus Children's Pediatric Specialists, the physician-led multi-specialty medical group practice of Nicklaus Children's Health System. Founded in 2001, Nicklaus Children's Hospital's Brain Institute is one of the largest comprehensive pediatric programs dedicated solely to the care of the developing brain, bringing together specialists in numerous pediatric neuroscience subspecialties. Since 2008, the program has been ranked among the nation's top-tier programs for pediatric neurology and neurosurgery by U.S. News and World Report. The clinical and research program offers the latest treatments and diagnostics, many of which were developed by the Brain Institute's team. So for today, Dr. Lallas is going to speak on the potential of electroencephalographic source imaging in pediatric epilepsy, And the learning objectives will be to recognize the contribution of electrical source imaging models in pediatric epilepsy surgery evaluation, to discuss the strengths and limitations that affect the validity of the electrical source imaging results, and to understand the current evolution and future directions in electrical source imaging. And Dr. Lallas, with that, thank you so much for being here, and we look forward to your talk.
Thank you so much. I'm really excited to be here today. This is a very big thing for me. I really am feeling very honored to be able to participate and to be the first speaker of the year. Thank you. Um, so with that, I'll go ahead and get started. So the potential of electrographic source imaging in pediatric epilepsy. I enjoyed the pun by putting the potential in there. But I do think that the end result of this is a talk about sort of at the very end, where are we going and where can this take us? With regards to disclosures, I do participate in some speakerships and some ad boards and do some research at the hospital, but none of them are going to be relevant really to today's discussion because today's discussion is going to be about just the EEG and none of this is that. So the learning objectives, as were stated, is to talk about the contribution of ESI, its models in pediatric epilepsy surgery evaluation, to understand, why some models are helpful versus what are the limitations we need to be aware of, and then, like I said, where are we going with this in the future? The ESI is not something that is, in my mind, itself new, but there's always new things that are being done for it. It's been something that continues to evolve and grow, and that I think is really important for the purpose of how we think about the child's epilepsy when we're talking about treating it with a surgical approach. So epilepsy is something that is eminently common, unfortunately, and there's an estimated 51 million people living with epilepsy globally, with about 10.1 million who might benefit from epilepsy surgery. Now, that's globally, and that's all people. That's not necessarily all children, but children is, of course, a high burden of epilepsy, and we know that pediatric epilepsy surgery is underutilized. It's been recommended for a long time that we be encouraging people to seek earlier care with an epileptologist, that we encourage people to seek earlier evaluation for epilepsy surgery. And yet, despite that, referral rates for epilepsy surgery evaluations and actual surgeries themselves rates have been reasonably stagnant, potentially even decreasing. There's more centers out there that are trying to perform this and offer it to its patients, and it's not happening as often as it should. Our understanding of epilepsy, of course, changes as we know more about the genetics and how that could contribute to it. But even if patients aren't getting the surgery, are they getting evaluated for it? We know that when epilepsy surgery works, there's improvement in seizure freedom rate compared to the medications. There's improvement in quality of life and in developmental outcomes. And that, again, when it works and people are seizure free, there's a reduction in mortality rates. So it's really an important mechanism of treatment for a lot of these patients, and for them not to be evaluated is really unfortunate. So we want to be sure that we're offering it to people. We want to be sure that we're offering it in a rational way as well. And when we think about the patients who come to epilepsy surgery, we can wonder, why is it that they end up having epilepsy? And when we look back at a survey of different centers through the ILAE in 2004, just looking at that past year's patients, 42% of them were caused by some form of cortical dysplasia, with 60% of those, about 103, being lobar or focal cortical dysplasias. And then, of course, we had tumors, and of course, there are some times where tumors can be associated with the cortical dysplasia. We have atrophy and stroke, hippocampal sclerosis. Tuberous sclerosis complex is an important one, which is causing both structural and genetic reasons for the patient's epilepsy. And understanding that these patient populations have different ways to think about how we would approach their epilepsy surgery is relevant, and how does the testing that we do differ from different patients to different patient. So in 2014, there was a publication released in Epilepsia by the International League Against Epilepsy, where they had surveyed, again, a number of their centers to talk about the different types of testing that might be part of the protocol for an epilepsy surgery evaluation. And so if you look at the epilepsy surgery evaluation, I think we all know that it really hinges on the clinical history, the video EEG capturing both ictal and interictal, a high quality volumetric MRI, neuropsychology testing, as well as genetic testing. I think is playing more and more of a role in how we consider it in many of these patients. And then beyond that, the determination of when you need other testing in order to help you solve questions is very much dependent upon that pathology that you understand. If the patient is non-lesional on the MRI, you're more likely to require the other testings. And so if you take a look at the middle column of 5, where we're looking at how centers responded to whether a test was mandatory, highly recommended, optional, of low utility, or or unwarranted, and all the way at the bottom there, there's 15 to 40% of centers were saying that 3D ESI or MEG imaging would be needed would be mandatory essentially for the MRI negative cases, and 60 to 85% of those centers were saying that it was at the very least highly recommended. And as you take a look within the different pathologies, you'll find a variety of opinions about there, and there are some times where it's saying that, yeah, we really don't think that it's warranted, like potentially hippocampal sclerosis. But in those scenarios, I would argue that there's still information that we could potentially garner from this, and that might be helpful towards our understanding the whole network. But sure, we might not find our spikes on the hippocampus just from our scalp EEG. So, understanding that this is a technology that has been utilized for some time, let's get into the idea of like really what it is. And I posit to you that ESI is a very technical version of what we do all the time. So this is an EEG for a patient, and I'm sure that most people looking at it have already noticed that it's a bipolar derivation. If they looked at the montage, they'd know that I put the parasagittal chains on top and the temporal chains below. Some people might be saying, I really want the right side to be red and the left side to be blue. It's just how I look at EEG. I personally look at EEG where I like everything to be all the lines to be the same color, because I think it adds visual information otherwise. But people read it the way they read it. Either way, though, I think most people are looking at this and then saying, now that I know what the EEG looks like, where is that spike coming from? There's several spikes on this page, and I'm trying to picture in my mind where that comes from. And we can look at it and try and reconstruct it either through that bipolar derivation or, of course, through our average reference. And I tend to like the average reference because I'm often thinking about the whole field, and I'm trying to look for the positivity as well in that. And so we have this spike, and we think to ourselves in our mind, where is that coming from? But of course, 3D ESI is the approach of putting that directly into a computer and allowing it to show us in 3 dimensions that relationship, so that we can kind of show people that that's what we're talking about. So in general, our workflow when we're looking at EEG is that we have the EEG and we try and picture that. That's what we call the inverse model. And the inverse model is complicated because, of course, we have to take into account the the skin, the CSF, the brain. The inverse model has no one clear solution. There can be many, many, potentially infinite numbers of solutions. In general, the reverse is much easier, where where we know where the current is coming from, and if we have the current and the brain and the conductivities and all those things predicting the EEG, should be for the computer relatively simple, and there should be essentially an answer to that. That allows us to get some idea of the quality of our responses, but what we're trying to do on a day-to-day basis is the more difficult response. So if we think about where the EEG is coming from, right? We know that the EEG is coming from the activity in the cortical layers, the extrasynaptic activity, and that is the electrical field that is essentially coming outward. So if we have this activity that is negative on the surface and positive in the deeper cortical layer, then that electrical field projects outwards, but it's got to go through the CSF, through the bone, through the skin, and each of those processes is going to spread the current outwards, right? Which is going to attenuate the signal. And in the meanwhile, once that current gets to the scalp, it can't really go anywhere in the air, so it all comes together into the electrodes. The end result is whether we have this outward going current immediately, or whether we have a more horizontal tangential going current, when it's being read, the EEG is essentially looking kind of like this at the brain. The brain is not as highly detailed as we'd like on our standard EEG because it's looking at large scale areas that have had their activities attenuated as well as summed all together. And we can see the activities that are going tangentially because we have electrodes that essentially are on either side of sulci, but we don't have them typically around every single sulcus. So we're seeing this activity less clearly. Often people are asking me, of course, about MEG because it's a related technology, and MEG. I'm sorry, this is the idea again of our tangential appearing activity versus our and how we can see that, and we can see the dipole showing up in between essentially the positive and negative. Versus in a radially oriented dipole, he's going to end up being right underneath that peak negativity. And what I was skipping to a moment ago was the idea that the MEG is a related technology where what we're seeing instead is the magnetic fields. And really the magnetic fields across the sulci tangentially on the bank rather than at the crown of the gyrus are the ones that are visible to the recording devices of the MEG. And as a result, if you've got signals on both sides of the sulcus that cancel out, you might not see that. But if you have an unopposed signal at a sulcus, you can see that pretty well. And MEG comes with many more sensors for higher resolution. And also as the magnetic fields pass through the scalp, the skull, the CSF, they do so in a way that is essentially invisible to it. So you get a much cleaner, unattenuated signal without any of that damping or shunting effect. And so you get higher appearing resolution, but you can't really see as well the activity at the crown of the gyrus. That radial activity is essentially not well seen unless it's shifted and oblique. So there's limitations to what you can see on the two. So talking then about the models, there's multiple different ways that we visualize this activity when we are taking it. Once we put it into the computer, we want to understand where is the electricity actually coming from on what part of the brain. But one of the easiest models and most clinically used models are the dipole models, where in essence we say, if this is the EEG activity, if this is the voltage topography that I have, what is the current that will explain the most of this signal? So when we're doing the dipole model, we're making a simple representation of that current. Now that because that current is meant to be seen as sort of a simple representation, it looks kind of like a pinpoint location. But often it's really deep to the structure of interest because, of course, the source is not a single pinpoint location. It's an extended cortical generator. So the way to think about the dipole model typically is to say, if I have this dipole and it's deep to the area of interest, what is the area of interest that is along the trajectory of that dipole where the dipole is sort of a circle for the negative component, a stick for the positive component. I want an area of cortex that adequately is aligned to that region. That's really the way to think about it. And to focus so much only on the localization of where that dipole is may be missing some of the important features. So really understanding the orientation data of that so that you can find an extended cortical region that explains that source can be extremely important. The distributed models have been developed, and these, I think, are often very appealing to people to look at because, in general, what we've learned to do is constrain them to the cortex and make them look kind of like a blurry area of cortex, like a heat map that says to you, aha, now I don't need to do so much interpretation about where is that dipole coming from. That makes it visually very appealing. But these are extremely complex models. They're mathematically complex, and the way that we've made this constrained to the cortex is really an artifact of how we want to see things. Because we could just as easily leave this as a three-dimensional grid throughout the brain, rather than having it constrained to the cortex, or having it look like our cortical activity. And we can also be adding parameters to it to say, we really only want to see activity if it reaches above a certain threshold. And the problem with this is that if we have a lot of user independence in it, and suddenly we start saying, well, this looks true, so this must be the area that needs to come out. And that's not the case, right? This is a statistical test. This is a statistical model of the activity of areas that are likely involved, but it's not necessarily true that you just need to take this whole area and you'll be fine. It may, however, be more intuitive for planning surgery because if you know that an area looks like it's going to be involved based off of the mapping, then you can say that's where an area where I want to be putting some of my either stereo EEG electrodes or some of my grids and strip electrodes in order to understand that. And you may add some locations if it makes sense for the clinical correlation as well as along with the EEG activity. But really, like I said, the fact that it looks this way is because we want it to. It makes it easy for us. Another way of thinking about it is essentially like this is just a whole bunch of little dipoles in little voxels. And because of this, some of them are actually mapping it out as a current. And now you've got a current in a voxel. So they say that's a current density. So a lot of them are referred to as current density reconstructions. In this case, this S-Loretta model that I have for this example is actually not showing current. It's actually showing an F statistic. So it's trying to show us the likelihood that a specific area is involved and then the direction of that activity. But again, it's just another way of visualizing and understanding that visualization is so that we can understand it. It's not necessarily the truth is important when we put all these things together. So the indications of ESI that are generally accepted include when a patient has a intractable epilepsy being evaluated for surgery and they have no structural lesion identified on their MRI. If they've got multiple cortical lesions and you're trying to identify which one might be the cause, such as in a case of tuberous sclerosis. Cases with large cortical abnormalities where you think that potentially only part of it might need to be resected or be the likely driver of the source of the epilepsy. Discharges with bilateral synchrony, but where the patient's clinical characteristics suggest some focality, are important to consider that maybe we could find a difference in timing between the activity to the two hemisphere. Traces where it's difficult to interpret the fields could be a consideration. Neocortical epilepsy in the setting of post-infection physical and vascular injuries are also accepted reasons to be doing this. And again, all in the idea of trying to service that surgery evaluation and consideration for how we might move forward with this patient. So here's a patient who was seen and ended up having intractable epilepsy. The seizures were quite frequent, and on the initial MRI, there was not a lesion that was identified. So in part of the planning to move forward, we did plan for the updated MRI for the high density EEG with the phase one with a PET scan. The high density EEG we do as a brief test. It's not it's not a prolonged test. But we did end up finding this dipole here that I'm showing for this small spike, right? So this dipole is relevant. It's sort of hard to understand just taking a look at it because, gosh, it shows up right in the center. And it shows up with that negativity in the center, but kind of pointing up and toward the left. Meaning that the positivity is pointing up and to the left, meaning that the dipole is directing down towards the base of the right frontal lobe. And if you can see, there actually was a finding that we got on our pre-surgical MRI in this region here, right here at the base, a little, just above the orbit. And as we take a look at that on our current density reconstruction, I've also co-registered in the flare. And you can see that on the flare, there is also a bit of a hyperintensity in this region here. So it's a little more, it's a little stronger response on the S-Loretta on the distributed model, just a little medial to that. But in general, it's close, very close to where this lesion is. And like I said, because of the pre-admission data that we had, we also planned a PET scan, which meant I could correlate that too. And now we can see I've turned off the visualization of the dipole and the distributed model on these planes, but we can see that that PET scan is really agreeing very much with the MRI lesion as well as with the distributed model, and that when you take into account the orientation of that dipole, the fact that it's midline and potentially along the left is less relevant than the fact that it's actually pointing right down to this area. And I included this slide to show you that we can even test and show a goodness of fit data for how well the distributed model is supposedly explaining the data at this time as we're in our rising phase of this spike. When we took this out, we did just a one-stage electrocorticography, putting the EEG strip underneath the floor of the frontal lobe, and you can see, I think, right away where we have this periodic activity that is, irregular but predictable as far as when it's going to occur. It's discontinuous. And this was found to be a meningoangiomatosis, which is a hematomatous malformation that can be associated with epilepsy and NF2. And in the genetic testing, they found a chromosome 22 partial deletion, including the NF2 gene, which was not seen in the peripheral testing, was only found on the pathology. Here's another case. This is a case of a patient who had prior epilepsy surgery because of tuberous sclerosis. And I think you can see that there's a large area here that there's essentially the hole from the prior surgery. And the patient was seizure-free for 5 years before seizures returned. The seizures have been back for some time. Seizures are a little different now, but the patient typically has these bursts of activity, which are very, very much both sides being active, but not quite synchronously. And they become very complex, and this occurs both indirectly as well as the beginning of the seizure. So this is a single spike analysis for the very beginning of this spike. And if we can see, this spike is showing up in this anterior frontal region right here. The dipole is pointing to this base of the frontal region. The distributed model is very much in agreement with it. So do we have any tubers in this location? So we've got a few. We have one that is lateral to the dipole and lateral to the distributed model. We have another that, this is a little hyper intense, but, isn't necessarily as bad as the other tubers. We've got this tuber down here in the temporal at the base. And then we also have this one far forward. And this one, if you ask me, I think is actually really much more a candidate based off of the location and orientation data, as I mentioned. But one of the things to also understand is that we are dealing with a number of areas where our typical opinion of the cortical organization may be abnormal. And so we may be dealing with some altered and closed fields, and we may be having a hard time getting perfect localization. But in general, we've got a number of very specific target tubers, and this would be the one that I would be most concerned about. I am not at this time going to be able to tell you if I'm right. Maybe one day in the future. So these two cases illustrate some of what I've talked about how the ESI can help us with cases where the MRI is negative, although again, that first case wasn't actually MRI negative when we got our epilepsy surgery protocoled MRI done appropriately, but on the initial outside one, it hadn't been shown. Also on the case where we have the multiple malformations and we want to try and pin down between them. What are the other ways that we can think about how beneficial this is contributing to pediatric epilepsy surgery evaluations? So one of the largest prospective studies is from a group that did 152 prospective analyses in both low resolution ESI and high resolution, meaning that they were using electrode caps of 64, 128, or 256 channels. And in this study, they were using average spikes, and we're going to talk about the difference between average and individual spikes, as well as using a distributed model, and they looked at the surgical outcome. And what they found was that utilizing the high-resolution ESI, where they included the patient's own individual brain to make the brain model, and they were using the 64, 128, or 256 channels, that test had a higher sensitivity and specificity than any of the other tests, including the MRI itself. Although I would argue that since the MRI is being used for it, that makes sense because it's participating. But either way, the MRI, certainly you can say that it's a higher sensitivity and specificity than the PET and the SPECT scan. Interestingly, the numbers are not as great, but still quite good for the low resolution ESI, just using somewhere between 19 and 29 electrodes, the standard 1020 plus or minus 10 to include subtemporal plus a few higher. Um, the study looked at it based off of the surgical outcome, patients doing quite well. And if we're taking a look at these numbers, we're seeing numbers about PET and SPECT sensitivity around the 60s, which is about typical. We also looked at this in a number of our patients retrospectively, and this was a review of 60 patients where we did something slightly different. Here we're looking at individual spikes, and we were modeling dipoles rather than modeling the distributed models. And our electrode count was a little different because for our practice for a long time, we have utilized the standard 1020 plus some subtemporal electrodes. But if we have pre-admission data where we understood where the seizures were coming from, or we had a good hypothesis about where the seizures may be generating from, we might add an additional up to 10 electrodes to the area of interest so that we could better localize in that region. And this was based off of some data from a simulation study in 2005 that was done elsewhere that suggested this could be a valid model to understand the dipole activity. So we would do what I would call a locally dense EEG around that area. And what we ended up finding was with our data, we were getting, again, similar sensitivity and specificity, potentially improved sensitivity and specificity based off of resection outcomes at 1 and 2 years from our rotating dipoles and their localization to the seizure resection zone. We looked also separately at our patients with MR negative cases, and with a similar paradigm, because again, this has been part of our standard utilization. But here we look not just at the rotating dipole, but also the moving dipole. And again, with this smaller number of the specifically MR negative cases that we were able to look at, we had a high sensitivity and specificity at 1 and 2 years, better than the PET or the SPECT. So the moving dipole and rotating dipole that I just mentioned, what am I talking about? I mentioned earlier that there's the dipole model and there's the distributed models, but of course, there's multiple different dipole models and there's multiple different distributed models. The idea of the moving dipole is that the EEG is, of course, multiple samples back to back to back to back that allow us to see the waveforms that are active. Well, we can sample along every single time frame in there. And as we do that, we can allow it to say, what is the location, orientation, and strength of a dipole at this time where it's red, at this time where it's purple, at this time where it's green, and this time where it's more green. And that allows us to get an idea of really how is the activity, how is the current that is being predicted moving around. Of course, the earlier in the spike that we are towards the baseline, maybe the more noise is contributing, and the higher we are, maybe the more the propagations effect. But this gives us sort of a visual representation of that too. The rotating dipole, on the other hand, is saying, you know what, I just want it to fix the location at one spot, find the best spot that accounts for this short time interval, but allow it to rotate and orient and increase in strength throughout there. So these are two ways of looking at it. And if you take a look at a rotating dipole and it's just spinning every which way, you're going to say there's probably a propagation effect in there, and that should be simulated also by the moving dipole. So we looked at both of these in that study that I mentioned before, and again, considering both of them helped us to understand and to do well and have a high sensitivity specificity when we looked retrospectively at our data. So this is a prospective study in 28 patients that was done where it was really a question not just of the analysis, but how did it impact, how was it concordant or discordant with the preoperative data, and how did it impact and add value to the planned implantation and ultimate resection that went on for the patient. So this was confirmed by stereo EEG, where they were looking at equivalent current dipoles as well as distributed models, and they were looking at 64 electrode count EEG. And it was considered to be having an added value when on stereo EEG, the findings from the ESI confirmed, restricted, or added valid localizations that wouldn't have necessarily been considered based off of the electroclinical correlation or the MRI alone. And Their results were that there was a high amount of concordance, either partial or full concordance, across the study. So you can see the patients here where we have a negative MRI utilizing the 64-channel EEG recording and averaging doing some analysis of individual spikes. Here are the equivalent current dipoles, and here is the distributed model. So they placed electrodes in these regions and were able to find similar activities on the stereo EEG as suggestive of being involved in the seizure onset. All the MRI negative cases had at least partial concordance, so 73% of the MRI negative cases noted an added value from the ESI, meaning that it contributed to the recording and to the ultimate outcome. So here's a solution for us, right? As I mentioned, we were talking about the idea that the EEG, because we have a small number of electrodes, because the activity is being attenuated when coming out and being dammed together when it's on the scalp, is looking at the brain like it's essentially a very smooth area, a smooth surface. By increasing our number of electrodes, we have one solution towards how we can improve our resolution. Well, that's not necessarily the only one. And as I mentioned, we have been utilizing a different practice, which is in many places considered controversial. People talk about the idea that you really shouldn't be doing non-uniform sampling. And I think that there's a fair point to the idea that we shouldn't be undersampling anywhere. And that we also do want to understand both sides of the dipole. So, only getting the negative peak might not be sufficient. But at the same time, there's a group that has looked at it very recently, and I like their terminology better than mine, which I had mentioned earlier was less sort of a locally dense. They said a targeted density, but they started with high density EEG, capturing an 83-channel montage, but then only looking at the electrodes on the standard 1020 system with the included subtemporal electrodes, and then saying if the area of the maximal potential was in F7, let's find 8 to 10 electrodes maximally around there to understand that better and see how much is it different compared to the analysis that we will get by doing the whole 83 electrodes. Because in general, if you're doing this in the software and you are getting a result and you have 120 electrodes, you can downsample those electrodes. And if you're concerned that a non-uniform sampling is potentially somehow providing additional bias, you can turn off the non-uniform electrodes and just deal with the standard electrodes. What they ended up showing was that actually, quite typically, the sublobar concordance, or even sometimes subgyral concordance, was quite high between the targeted density versus the high density. So in the setting where you don't necessarily have a high density EEG, but you may have the ability to know in advance where the electrodes are where the expected signal will be, having a plan to put additional electrodes around there may be beneficial. So I've been talking mostly about interictal. I think I've been talking actually exclusively about interictal analysis, but ictal analysis can be done. And in this review of ictal analysis, that was also taking a look at, again, that same contribution that I was talking about. How do the channels that are being utilized impact what we are doing and what we are seeing? And so all the way over on the right, we have our 76-channel layout for a high-density EEG. And then they took a look at it in comparison to this 25 channel where we've had the 1020 plus the subtemporal. This is not a study. This is a review. It was a demonstration. But if we take a look at it, we can see in both of these cases we have this very nice inferior temporal activity that they've modeled that they're showing here. But interestingly, we got a similar one for the non-uniform. When we just had the 1020, the activity is been pulled up. It's no longer down where it should be because we don't have that subtemporal coverage. We're not seeing really the whole range of that dipolar field. And that's important. If we go back to that patient that I had mentioned earlier, the tuberous sclerosis patient, this patient did not have the subtemporal. So while I have a suspicion about this being the one of interest, I can't entirely exclude the possibility that it could be that inferior lateral temporal tuber that I had mentioned as well. This image I've parsed a little bit. It comes from a study that was involved in looking at the contribution of electrical source imaging versus magnetoencephalography. And they looked at a number of patients, but this one patient they actually broke down and looked at a little differently because they wanted to see the contribution of changing your filter settings in your analysis to understand how that would actually impact your data. And if you take a look at it, they checked this patient with 64 individual spikes at different high pass filters of a half a hertz, 1 hertz, 2 hertz, 3 hertz. And you'll notice how much dispersion there is. Now, this MRI brain that they have modeled is the post-operative, but of course the analysis was done on the preoperative. And you can see that the dipoles are oriented much more different directions, much more variety. They're not quite as tight in their localization, and they get closer and closer and closer until we get to about 3 hertz, 4 hertz high pass frequency. And then they start to actually disperse and reorient a little bit again at 5 and 6 hertz. So the question becomes, is this something that is specific? Is this 3 hertz something that is specific to this patient, or is it something that is better to understand? In general, our goal should be how are we going to increase our signal and lower our noise? And if we have a spike that is an individual spike, one of the ways might be to try and remove some of the slowing from the background before it. And if we take a look at the averages of each of these, where these colors for these average dipoles represent the dipoles for all the half hertz high pass frequency if it's in red, for the orange, we can see that they still end up roughly the same location, but having this idea of what is the dispersion could, in theory, potentially add some benefit. So when we take a look at that, again, they found in this scenario that they had the lowest distance from the average dipole location for all of the individual dipoles. They had the smallest confidence ellipsoid, which is, think of it like your 95% confidence interval of where the current actually is, and the highest goodness of fit, meaning the most explained signal in that 3 hertz. So this is something to consider. Should we be utilizing 3 hertz in our analysis? Should we be testing 2 and 4 to understand? A lot of the studies that you'll find out there, they're talking about utilizing the analysis without actually saying what their filter settings were. And some of them will be specific about it, and that makes it a little difficult sometimes to compare one to another. As I mentioned, averaging is something that is commonly utilized and that I would talk about. So here, if we take a look at this evaluation, here we have got a single spike. Here we have an average of 10 similar spikes. And here we have average of 25 and average of 100. And if we take a look at how those did, it shouldn't be that it shouldn't be thought that they only evaluated one spike of 100 average. They actually had several because they had enough spikes for that. Here they had several for the 25. And the more and more that you averaged, the higher your signal to noise ratio was because you eliminated a lot of the noise, which meant the tighter an area that you identified. Versus if you had single spikes and you didn't use anything to try and filter out whether it was a worthwhile spike, we got this really large dispersion area of the spikes. But if you then said, well, I only want to keep the dipoles where it meets a certain threshold of how much of my signal is being explained, at least 90% of my signal, or at least 95, we now excluded a number, and we get very reasonable data out of that when we consider that these patients were known to have large cortical dysplasias. That's what this study was evaluating. So utilizing averaging of spikes to understand, to increase the signal and decrease the noise is a very valid technique, but you have to be careful about it because it's very possible that you could be taking spikes that seem superficially similar, but actually are coming from slightly different orientations. And then they represent different populations of cortical areas. And now you're actually smoothing that out. You're actually decreasing the specificity of your average because you're averaging two separate things that look kind of similar. So the strengths of ESI is that it's non-invasive. It's got the temporal resolution that we have from EEG, which is very high. It basically almost always is going to be correlated with the other imaging modalities because you're almost always going to be utilizing the patient's own brain, which means if you have access to that data, you can get access to the other modalities as needed. And that you've got evidence that it can improve surgical planning and precision, so that it can help us with identifying the right places to be going. What are the limitations? Well, the signal to noise ratio is a problem. Accounting for anatomical and physiological limitations, variability in electrode placements is going to be different from location from center to center, and lack of universal standardization across centers, and a misunderstanding of the interpretation of those dipoles or of those distributed models can be a problem. So really understanding that we have to keep a lot of things in consideration here. Are we going to do ictal versus interictal, or do we need to do both? Are we doing single versus average spike analysis? What are our analysis filters, and do they need to be adapted patient by patient? Do we use the individual head model versus, for one reason or another, this patient, we can't utilize that? This is a testing that I would say you have to make so many choices at the beginning that for a clinical purpose, it's not unbiased. We can't just say that we're blinded to everything else. In fact, you're very much unblinded to a lot of it. So you have to be, again, cautious. You want to understand the data as best as you can, and hopefully it makes sense to the information that you have. And if not, you have to ask yourself, is this because I'm offering new data, or is it because there's something wrong with my model? So future directions. So this was a study where they looked at not just ESI, but also at how it could be utilized in a way to look at directed functional connectivity. What they took was they took the EEG signal across the time point of an average spike, and they turned that into a distributed model, an S-Loretta model. And then they said, well, now I've got this whole brain activity because I can model it in theory across the whole brain. Let's parcelate that brain out into smaller individual brain regions of interest. So they utilized the AAL atlas and created the centroids in the sublobar regions, and looked at the weighted partial directed coherence to look at the directed functional connectivity. And what they're essentially trying to look at is, how is this network communicating, and how is it understanding? And of course, what we always want to know is, where is the seizure coming from? So both the ESI and the directed functional connectivity localize the epileptogenic zone in 90% of the TLE cases and 57% of the extratemporal lobe epilepsy cases. So this is a way of me saying there may be a lot more we can do with the ESI data to understand not just our localization, but also the networks that are ongoing in these patients. This is another study where the part of what they were looking at was just, if we look at the visualization of the EEG over a three-dimensional representation, can a person just say that that's where it's coming from reasonably well as hopefully the ESI does? But another thing that they looked at and commented on is something related to a question we get very frequently when we talk about these things. Do you evaluate the spike at the peak or at the midpoint of the rising phase? And I get that question a lot when I talk about this, and my answer is always the same. Yes, I do. I look at both the peak and the rising phase. In fact, that's why I talked about the moving dipole a little bit, because that's giving me an idea of propagation. In general, you want the earliest source, because that's going to give you some idea, hopefully, of where the seizure is coming from, right? We're looking at spikes, which are by definition really about irritative zone, but we're hoping that we're getting some idea also of seizure onset zone. The earlier you can do, the better, but you get too close to the baseline and you have too much noise. The midpoint is a good compromise between that and the peak, where there may be propagation. But if you've done a moving dipole or a rotating dipole and you find that it's been very, very stable across all of that, then the peak may offer you sort of the best estimate as far as a visualization, because it's by nature already been shown to be stable, and it's a high signal to noise ratio. So in this study, they actually kind of looked at the average spike at the peak and at the 50% point, and they identified some patients in which they had the 50% point and the peak being very close together, where they localized on a distributed model, and others where they were actually quite far apart. And not surprisingly, the patients where they were close together versus where they were far apart had different outcomes. So this is suggested that the network was potentially broader, and therefore, hopefully, these patients did not do as well. Another evaluation, we've been talking a lot about, again, high density, but high density does not necessarily need to be the only way of doing it. And aside from just getting dipoles and looking at average spike dipoles, can we look at the dipole cluster if we look at the individual spikes? Because as I mentioned, it's a problem if you end up averaging things that are actually not the same signal. So the group at Cook Children's took a look at dipole locations for low density EEG, for high density EEG, and for MEG, which again, MEG can be utilized to do this activity, to do this analysis in 3 dimensions because it does a very similar recording of brain activity through the magnetic fields. And so in this case, what they ended up doing was they ended up saying, well, I've got these individual spikes and I want to consider, how well do they cluster together? And they created a metric for clusterness where they said that the clusterness is the number of dipoles within 15 millimeter radius of this individual dipole divided by the total number of dipoles that met their goodness of fit criteria. So if they analyzed hundreds of spikes and got hundreds of dipoles, but some of them were not fitting very well, then those ones were not included. And if they ended up with these ones, you can see that they have very tightly packed cluster in this 15 millimeter radius around this dipole. So this dipole gets a value of clusterness versus these dipoles don't have very many packed around them. So they're going to get low values of clusterness. And they looked at each modality and they found that, they had different thresholds, but each modality was able to provide a value that could be used as a cutoff for high concordance and for high predictability. And in general, is able to provide sublobar or gyral concordance. And that's partly related to the fact that they use that 15 millimeter radius and the idea that that's going to be based off of essentially the size of a standard gyrus. The same group also looked at the idea of virtual sensors. I call this virtual implantation because they actually are comparing the EEG data from the scalp to later data that they got from actual implantation. But they're taking a look at this, and so there were sensors at some point, but the data that they're comparing it to is now data that they create virtually, where they looked at initially the scalp EEG for seizures that were clinically similar to the ones that they got on intracranial EEG. And then they projected those onto the brain through a distributed model. And then through that distributed model, did a forward model to the electrode locations to sort of understand what would the EEG there look like. And they found moderate agreement between the seizures they were able to simulate in their simulated virtual sensors to the ones that were able to be clinically recorded. And when they utilized that to sort of plan out a virtual seizure onset zone, again, it was predictive of the actual seizure onset zone that was resected. So there's some idea that this could help us in planning, again, where we want to implant and how we want to implant. And importantly, they were also taking a look at depth electrodes, and this was not limited only to surface positive electrodes. So coming back towards the beginning, we talked about this EEG, and I said that all of us are kind of looking at this and in our head trying to understand almost automatically where this is coming from. And so I did that. This is the moving dipole and a distributed model. And if you take a look at it, this is an average of 10 spikes. So initially I found one spike that was somewhat low in amplitude, and I asked the system to find similar spikes. And I actually had to use a low amplitude and not as high of an agreement across them as I would like. And I got this spike here. This is also filtered to 3 hertz, and it's only 10 spikes that were averaged. This is the moving dipole across this phase here, across from here to here on this spike. And, I'm not able to rotate this live right now because we're just in PowerPoint. But in general, there's a appearance of the dipole being one direction here where it's green at the end versus a different orientation and direction earlier on. And of course, I've got my distributed model at the same time. So what if I did what we were talking about earlier? So here is the dipole at the mid phase of this rising for the spike. And it's oriented essentially pointing out towards us with a confidence ellipsoid that is, only so big, about 2 gyri wide. Versus here is at the peak. Our confidence ellipsoid has dropped because our signal to noise ratio is higher, but we have a different orientation and a slightly different location. Not very different in location, but by orienting, we're talking about a potentially different cortical location. So now let's talk about what we did if we modeled each spike at the half rising point, and I included in it the average across those spikes. And again, we have those significantly dispersed. This is not very tight appearance. But if I then said, well, what if I did a low frequency filter of 3? Because the past one was at a low frequency filter of 1. And now, okay, there was one down here that isn't there anymore. It's actually come a little closer. We've potentially gotten rid of some of the noise and increased our signal. And then here I've said, well, I only want to see the spikes that at least explain 60% of the signal. And now I'm looking at the same thing where it's the spikes that explain 60% of the signal, but at the peak. And more of them have been able to stick around because, again, our signal to noise is higher. But I'm trading the fact that I may be looking at an area where I'm getting a later cortical involvement. This was the same thing, essentially, but I found a higher amplitude spike to serve as the basis of my template match. And in the end, I ended up with 120 spikes. And that was with a really high level of agreement across the spikes. And when I did that, look, we also have not just this rising phase of this peak of the highest amplitude, we also have this earlier component too. So across this whole thing, the mid-rising phase is actually where we have a dip in the mean global field power. And here we have the goodness of fit of 60% for the 120. So not all 120 of the dipoles, just the ones that are better than 60%. Here is at the peak, where again, we've got a very similar location. But gosh, if I look at this area, this is the same spike. I've just now taken it off that sort of butterfly view. This was the peak of that earlier part to it. And so it seems like at the moment of that peak, it was up here. Then it came back to here when we were at this dip, and then it came back over to here. So this is an activation that seems to be moving around. And if we take a look at these dipoles, which I've saved, we can see the green ones and the blue ones. These are not the different time points. This is not the moving dipole. These are the same dipoles I just showed you. We can also look at it at the voltage topography across time as we're moving forward. And so left to right, we can see at the very beginning, we have this tight negativity and positivity here at this peak. And at the very end, where we have this peak, we have a reversal of that, a negativity here and a positivity here. Although interestingly, we can also see there's another kind of thing going on the other side of the brain. And it seems like it's actively growing as this dipole is setting in. And if we look back, we can actually see that same reversal on the other side. So something that I haven't really talked about is I've been modeling all of these as single dipoles, but maybe these ones aren't best modeled. Maybe there's some concern that we need to be separating out from the single model to more than one dipole or to using spatiotemporal models. Ultimately, I didn't go that far. I thought that this would sort of illustrate the point that there's a lot of ways that we can be utilizing to understand these patients' data, and that utilizing some of these things is going to help us move forward with what we're going to try and propose when we when we have a patient in front of us who's having a hard time with their epilepsy. So ESI makes valuable contributions in the evaluation of pediatric epilepsy surgery, similar or better than other accepted functional imaging studies. It requires so much consideration of other parameters, but when you are doing it, you can figure all that out to try and get a meaningful result. You just have to be careful not to have too much of a confirmation bias and only be looking for results that you get. You might get other results because maybe there's actually some data that you're adding from the discordance so that you need new electrodes, or maybe there's just a problem with the model. Understanding the models is critical to get that interpretation, but also to communicate it, where the people receiving it need to have an understanding of what it is you're trying to show them. It doesn't necessarily require high-density EEG, but definitely adding subtemporal electrodes so that you're not getting that displacement of the current higher up. And these techniques continue to evolve, which makes standardization difficult, but is going to allow for improved quantification of the results over time and hopefully for agreement across centers about how to do things in different ways. So I just want to say I've got a great clinical team here who I'm very happy to work with and very thankful for. And with that, I'm going to lead to questions because I got right to the end.
Fantastic. Wow, what a great talk. I have so many comments and questions that I've written down, but now is the time. So if anyone has any questions, you can write them in the Q&A section. And in the meantime, yeah, I'll start off with a few of my own questions if you don't mind. So, where to begin? Um, First of all, so your talk is about pediatric ESI, and just sort of broadly, I wanted to ask you, do you think that there is a difference in indication for ESI across pediatric populations versus adult populations? Or was your talk just about pediatric ESI because that's the population that you work with?
I think that when you take a look at pediatric patients versus adult patients, we have a number of things that it's really when the patients present, right? So the patients have focal cortical dysplasia still are sometimes being treated at adult centers, right? But we have a number of patients who have, tuberous sclerosis who we could be intervening on earlier, well before they get to adulthood, right? We have, when you consider hypothalamic hamartoma, which I wouldn't say is really going to be something that ESI is going to be super helpful, but that's going to be a pediatric condition in many cases. You have Rasmussen encephalitis is usually starting in a pediatric age range. Again, not necessarily something that you would say is yeah, great indication for ESI because it's going to be a much more hemispheric process. But ultimately, the idea of where this falls in is going to be based off of your pathology. And a lot of the pathology that we see in pediatrics lends itself to an important understanding of it because we may have one large area, because we may have multiple areas, or because we might have that negative MRI.
Yeah, okay, that makes sense. Um, Great. And then, again, sort of a broad question. So it's been shown, you pointed out multiple times throughout your talk that ESI has been shown over and over to have utility in the pre-surgical evaluation. And yet we know that it's very underutilized. There was a 2022 publication that came out recently that did a survey of the NAEC centers, of which there's something like 327, and only four reported that they did incorporate ESI into the pre-surgical evaluation. And they were all pediatric centers, which I think was also interesting. So, your talk emphasized the importance of it, but also there are a lot of considerations, as you discussed. So, how can we get more centers to simply incorporate this into the pre-surgical evaluation? There are considerations which may be perceived as barriers by some centers. So, what's your take on how we can best encourage people to use this more, given that we know it has utility?
Yeah. So I think that there's a number of answers to that, and I think that part of it is related to the time it takes to learn and understand how to do the procedure and who's going to be doing it, um, uh, what is going to be the means of getting it done, the software that you're going to utilize, how's that going to integrate into your workflow, and there's a lot of hiccup points, but they're all things that are solvable. There's semi-automated source analysis that could be possible done based off of averaging of spikes through services for that, and that may mean that okay, so your team isn't going to do the analysis, someone else will be, but that's okay. You can incorporate that data, and you're making certain assumptions about the averaging of the spikes. But again, that can be okay because that can be how you get the signal to noise. You just have to be in consideration of that. If instead you want your team to be utilizing it, then you're going to have to go through an idea of, well, are we going to do low density, high density? Are we going to be utilizing the open source softwares because there's a number of open source softwares that allow to do it, or is it going to be through the commercially available softwares where you may be able to get a better training and you may be able to get more assistance when there's questions about how do I do a certain thing, but where there's certainly a cost to getting that. But of course, you're also going to be able to potentially bill for the service. So from the practical standpoint, I think that there was a talk, I think last year, that did that quite well. And so I'm going to refer people to Susan Herman's talk about the practical aspects of starting ESI and HDEG in their lab. I thought that was
Mhm.
a very good talk.
Yeah,
But I would say that really there's so many ways to get this done. It is time consuming, but it can be really important. And hopefully, we can be improving the quality of the care we're providing by identifying the sources better before we even go in, and maybe identifying sources we hadn't quite considered. So increasing the chance for seizure freedom. So
yeah,
I think I'm very much in agreement that it needs to be utilized more.
yeah, yeah. Great. Awesome. Okay, we had a question about when or what indications would you use ESI in preference to MEG and vice versa? And I have a question that kind of goes along with that. I also, when you were discussing MSI and MEG, and you were just talking about how MEG measures the magnetic field, there's also the consideration that the signal that you're trying to capture is a whole lot smaller than the electrical field, and it falls off something like 4 times the distance or something. So does that also come into play when you're deciding MEG versus ESI, and how do you think about that?
Yeah, so that's a great question. And I think that MEG is a very important testing for a lot of patients. MSI is really it's also underutilized, but part of the problem with it is that you need, a pretty heavy piece of machinery, and you need a lot of expertise in running it. You need the shielded room. There's a lot of upfront costs, and often when we're talking about the number of patients that we're evaluating with it, it's not high. So a lot of centers, don't necessarily have one or wouldn't be able to keep it up and running. So you're talking about then referring patients to go get the study if you're
Yeah,
not a center that has one. I think that the other important thing to understand about the MEG versus the ESI is that I don't think of them as competing. I think
right,
of them as complementary.
exactly.
As I mentioned, the ESI sees both the radial and the tangential dipoles, although doesn't necessarily see either of them perfectly. The MEG only sees the tangential, doesn't and some obliques, not necessarily the radial. And the question is, well, gosh, which one came first? Because sometimes you'll have a MEG spike that doesn't have an EEG correlate. Sometimes you'll have an EEG spike that doesn't have a MEG correlate. And that is relevant data when we're talking about the real source of where that spike came from. So if
Right.
you can do them both together, it's better.
Yeah.
Um, as far as the falling off of the signal, the EEG signal also falls off because it's going through, and it doesn't fall off as quickly as a matter of the electricity, I believe, falls off at the square as opposed to the quarter,
Yeah.
but it's being attenuated by the scalp and skull and everything. So
Right.
the I think that when you compare the two, there's still a high degree of accuracy out of MEG. There's
Yeah.
quite a high degree.
Yeah. And I like your point that, it's not either or, it's both. If you have both, do both. And I think it's similar to, well, should I do dipole fitting or should I do the distributed? If you can do both, do both. I really liked how you demonstrated your use of both, how the dipole may indicate a deeper structure, and then the distributed linear can complement that information, and you can really hone in on which area is most active at a given time point. Um, okay, so I had a comment slash question on the targeted density part of your talk. So
Mhm.
I have long held the I don't know if it's a belief, whatever. There's a lot of literature, not a lot. There's a publication, and if you would allow me, I could put you on the spot a little bit. But there's an image in this publication. It's by Michelle et al., I think from 2004. And it clearly shows that if you don't have even sampling across the head surface, it will bias the ESI results. It will pull the source closer to where the higher density of electrodes is. So I wanted to ask you about that. The the image in the publication, I could show you quickly or I can describe it. But so they start with 19 electrodes. So the whole thing has 19, and they start with the even distribution 1020. It's a visual ERP, so P100. So the source is known to be in the occipital lobe. When the electrodes are evenly distributed, the source comes through clearly. And then they slowly move the electrodes in other places, and you can see that it pulls the source with it. Now, a difference between what I'm describing and what you showed is that you had the even distribution, and then you added more in one spot. So in the publication that I'm describing, they pulled all of the electrodes to one area of the head. So they didn't have that sort of baseline even distribution. What are your thoughts on that? Can we, is there any data that show whether there's bias when you do it the way you did it, and to what extent? So I'm pretty
So
curious about that.
So there's absolutely bias when we do it the way I do it. Now, I will say that that targeted density was not our center. That was a different center. I hope I was clear about that. I'm not trying to take credit for anyone else's work, but like I said, we've been doing it sort of similarly for a long time, where we have a pre-admission hypothesis, and if we have that hypothesis, we'll add extra electrodes in that area, right? So my response to that other talk is I agree that I am potentially introducing bias, and I would say that as I mentioned before, it's already kind of a somewhat biased study because I
Hmm.
can't really do it blind to all the other clinical activities. I've had to
Right.
spend time, or someone has had to spend time finding those spikes. If you are finding, if you're putting the extra electrodes in the area where the spike and the activity of interest is, then you should be getting actually relevant data. I think that if you are putting it in an area that is completely discordant, then of course you're going to pull yourself away from it. But
Yeah.
one of the easy solutions, as I said, is turn off the extra electrodes. Look at that 1020 with the subtemporal and see if you end up getting something that is highly discordant across the two models, because then that's one way of evaluating whether your bias is actually causing you, a significant problem in what you're doing.
Yeah.
As I
Yeah.
said, when we looked back at the patients that we were doing, where we did that, and we had significant success, and the rationale that we had was based off of it was a simulation study. It wasn't based off of the prior clinical report, but it was a successful simulation, and it's worked for us. So the difference between what we did and what they did is we didn't have high density at the time, so we weren't excluding a number of channels. We were literally pre-planning and putting extra electrodes in specific locations when we had enough data in advance. Otherwise, we would just put subtemples.
Okay. Yeah. That makes sense.
I,
Great.
I really appreciate that question though, because I
Yeah.
I know
Thank you
I, I
for
think
letting.
I think I think the non-uniform thing, people are right to say you're introducing bias, and so we have to be cognizant of that.
Right. Right. And to your point, you are aware of the other non-invasive data that's been collected. So your mindset is a bit biased, but that's how we have to do it. We can't be blind to the non-invasive data when you're evaluating a patient. Yeah, so usually when I'm working with folks and I learn that they are adding extra electrodes, I point them to this particular publication and let them know about it, and then they can make the choice about whether or not they want to keep the practice of adding more electrodes in only one spot on the head. So, yeah, lots to learn still. Okay, so we had a question. In your experience, how frequently does ESI affect your surgical planning beyond the data you have already collected as part of a standard phase one evaluation?
That's a great question. I don't think that I've quantified that for our center specifically. I would say that it's possible that we could get some data that may be beneficial and potentially prevent them from needing some of the other data. Although usually, if we're going to have the patient, let's say, have an MRI negative case, we're probably going to want that PET scan, right?
Hmm.
But given how difficult it might be sometimes to get a SPECT scan for a patient because of the timing of their seizures, or maybe they're a patient who's going to require sedation. We have multiple lesions because it's tuberous sclerosis, and SPECT scan would be preferred over PET scan in that scenario, at least FDG PET. Then it might be that the better data that I can get is that source analysis, and it may provide us some of the information that I really won't be able to get through my functional studies because of all the logistical hurdles for those two. So maybe that helps me with preventing that next admission for the SPECT scan because we couldn't get it on the first one. Maybe that helps us get to earlier concordance in there. Can I give a rate? No, but we try and be reviewing this on a regular basis because we want to be understanding as best as we can.
Yeah, yeah, there are. Yeah, that's a great question. So sort of related, I had a question again about your high pass filter section, which I thought was very interesting. And in my experience, it's true that you get a slightly better result if you have a higher high pass filter, more aggressive. So I did want to ask, in the example that you showed, would those differences in the high pass filter and the resulting results, would there be a difference in your implantation plan based on those results and the differences between the high pass filters, or is it
So
similar
on
enough that it wouldn't really?
Yeah, so on that image that I showed, which was an evaluation of one patient with the 64 spikes, I would say that probably it wouldn't have necessarily changed our implantation plan. But I bring it up because if we also take a look at the idea of I'm going to be modeling a number of different spikes, and I don't want to average them because they could be different populations, and so I'm blurring my average. Well, how do I know that I'm really dealing with a broad network versus a narrow network? And that idea of the clusterness is an interesting one. But I also wonder, well, gosh, is that because I'm affecting my signal to noise ratio a significant amount?
Yep.
So these are just all ways that I'm trying to improve my analysis. But it might be that there's not a great answer in any of the scenarios. It might be that no matter what we do, we get this broad thing. I'm trying to find a reasonable target for the team without necessarily over interpreting and over causing. So I tend to use some things as standard, and I do tend to use myself the 3 hertz as standard. But I often take a look. We often take a look coming down to 2, going up to 4, or just at the standard 1, because we don't want to be incorrect.
Yeah. Yeah, I mean, in the end, the data is the data, and you have to deeply understand the data that you're putting in, and then the choices you have along the way to understand the differences that you're getting in each of the calculations. I mean, that's just such an important point. Um, okay, so another question, you showed a slide on functional connectivity and the potential contributions that could make in interpreting ESI results, which I totally agree with. I think that we think of EEG as it's the EEG that we're interested in, right? It starts in a certain area of the brain, and then what we pick up at the scalp, a lot of it, to your point, has been volume conducted, and so we get a smearing of the result. And so then, anyway, I guess what I'm trying to ask about is the spatial distribution of a given result and how functional connectivity can inform which areas of the spatial distribution are functionally connected, right? So leads to a better understanding of propagation models and which networks are involved. Do you think that something like an anatomical volumetric parcellation of the patient's MRI could offer similar information? So like a mapping of the known functional gyri, things like that.
Yeah, so the functional connectivity, the directed functional connectivity slide that I showed was from a group, and they actually, like I said, did parcel that out. They started by doing the distributed model throughout, and then applying the results to the centroids of a parcellated map.
I see.
Into a simple, well, I don't want to say simple, but into an 82 region. And part of that is because, again, typically what you're thinking about when you're doing this is you shouldn't be thinking that you're getting point source or point precision. You should be thinking that you're probably getting sublobar or subgyral precision. So
Yep.
if that's the case, regions of interest that parcellate that well are probably reasonable.
Yeah. 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 That's a great point. We're thinking about sublobar precision. Great. Okay. And there was a question about whether or not there's any non-commercial ESI software that is appropriate for beginners to familiarize themselves with. And do you have any other recommendations for beginners that might be in the crowd that want to get their feet wet a little bit but aren't exactly sure how?
Yeah, that's a great question. Beginners uh, is a variable term, because you might
Yeah.
be a beginner at EEG, but not a beginner at coding and open source,
Yep.
or might be really good at the open source. There's a variety of tools out there. They all have tutorials and online data sets that you can download. They all are available. Most of them are available through open source public licensing for academic reasons, and they'll take you step by step by step. I've tried to do it a few times with some of them because I'm trying to sometimes figure out how can we complement what we do with some of the facts that the open source community is usually where you get the newest implementations and the really state of the art activities, because the commercial softwares need to go through iterations and need to go through bug testing. So
That's
you have the
true.
problem with the open source that don't necessarily have that.
Right.
But as I try and take myself through, I tend to find I don't have much time and I don't have the patience to go step by step by step by step. And so then I never learn it quite right.
Yeah.
I would say though that it's out there. It's available. There's a number of different open source toolboxes for this. And if you have the time and you have the patience and you have the interest, you can absolutely teach yourself. And most of the time, they actually are willing. There's someone who's running this, and they're willing to set up like a school or a session with a few different events, or connect you with someone who can be like your teacher for it. So
Yep.
there's ways. There's absolutely ways.
Wonderful. Thank you. Okay, so I guess, do you have any, oh, hang on, there might be another question. Um, there was a comment that I don't quite understand. It says maybe industry shall stop providing any software. If it's a question on whether or not industry will stop providing software, I don't think that's true. I think that industry is continuing to develop software in this particular area. And as we gain more knowledge and understand better what the best practices are, I think the industry software are going to always aim for that. I hope I interpreted the comment correctly. Okay, so then what closing comments do you have? I mean, given the considerations that go into ESI and yet the underutilization and the utility of it, what would you like to leave the community with on this
I
topic?
think that when we think about ESI and what we are doing, our visual interpretation of the EEG is so important, but it's fundamentally flawed. And we can do it better by adding the techniques. Now, that's not to mean that people who are very good electroencephalographers cannot find sources. Of course they can. Of course we all do. But we can utilize this to communicate exactly where we believe something is coming from, to open up new possibilities of where something is coming from. And when we look at EEG in general, there is so much lying under the data that we're just scratching the surface for. So while ESI for dipoles and for current density reconstructions, we really only look for surgical considerations right now. I guess my question is, one day, could this help us understand a patient without needing to say that we're only looking for an epileptic source, but can we be trying to understand really their brain networks and their brain pathology? Can we be understanding, why they are having their difficulties that are beyond just their seizures? And I don't think until we adopt more quantitative techniques, we're going to really be advancing how we use EEG. So more quantitative techniques across the spectrum are necessary, and this is one of those.
Wonderful. Thank you so much. It's really valuable vision. Thank you. And a wonderful talk. We really appreciate your time. Thanks to everyone that attended. Um, and I guess until next time, thank you.
Thank you.
All right. Bye, everybody.